Good evening, everyone. I am Dr. Ahmed D. Abdulwahab. I am a radiologist working in Erbil, Iraq, and today we will have a talk about the art of radiology reporting. What is needed from us, how do we do it, and what is required to make a good radiology report. So first of all, we need to understand the importance of the radiology report. For the radiologist, the most critical component of the service provided by the radiologist is the radiology report. It is the formal documentation and communication of the results of a radiologic study or a radiologic procedure, and it may vary greatly in style, format, and effectiveness. So we need to make the best style, the best format, and to make it the best effective report that we can do. So this needs practice, needs time, needs experience, and we will try to show you that in this talk. The radiology report is the major cause of litigation of medico-legal cases against the radiologist, in which the radiology report has failed to effectively communicate the results. The general concept of the radiology report, it should be treated like the official and the legal record, and it should be professional, reflects competence of the radiologist, skill, knowledge, experience, and professionalism. The radiologist should proofread, double check the report, and should correct errors in spelling, measurements, and right and left. These are very common errors, to write something in the right side while it's in the left. Should double check the report before signing it. It should be grammatically correct. You should be fluent in the language that you are reporting. If you are reporting in English, you should be good in English. If you are reporting in German, you should be good in German, and so on. The report should not only communicate the findings about the patient, but also reveals information about the competency of the radiologist. Is this a good radiologist? Does he knows what he's doing or not? All of this should be seen or felt in the report. So our goal is to provide sufficient details for the referring physician to generate a mental picture. He can imagine what's going on just by reading the report. And he should know the suspected diagnosis and guide him to the appropriate next step in evaluation. We should advise him what's the next step in evaluation of the case or of the patient. So first of all, common styling. What we mean by that is we make the style of the report, the way of the report, shared between the radiologists that work in the same department or in different hospitals or even the whole country. The idea behind that, if we make the report more or less similar, it will prevent discordance in terminology between the reports. The same term means the same thing no matter what. If the patient comes to me, to you, to anyone, if we use the same terms, we will have reports that make sense. And it should portray sections of a group like-minded radiologists. You know, these radiologists, they share the same ideas and the same training and the same way of reporting. And that's why we should use common reporting terminology. We should use the same terms to report the same things. The radiologist report is a formal medico-legal document. You can go to court because of the report you have written. And there are a lot of cases of radiologists going to court because some misunderstanding. It's often the primary means of communication between the radiologist and the physician. Now, the report format. The report format should be a coherent format, and it should be independent, and the quality of the report should not vary. What do we mean by that? The key to clear and concise radiology report that will provide a reliable, high-quality communication is a coherent format. What do we mean by coherent format? The radiology report is a diagnostic test that should stand independent of the individual interpreting radiologist. If I interpret it, I will have the same idea that you will have if you interpret the. It should be independent of who's the radiologist reporting radiologist. We should all describe the same thing using the same terms or as much as alike as possible. The quality of the report should not vary as a result of being differently interpreted by different radiologists. This is very important for statistical quality control. If we use the same terms, it should be the same same thing by the radiologist. Can you please mute yourself, please? The reporting format, if we use the same reporting format, this will ensure that the important issues are addressed systematically, okay? And they significantly improve the ability of the report to communicate effectively, and the variation in the report format create confusion for the reader. So the control of the variations, if we minimize the variation, it will reduce the liability risk because it ensures that the important issues are addressed systematically. And using a standard format will significantly improve the ability of the report to communicate effectively. If we use the same form, all of us, the communication will be much more effective. The variations in the report format create a confusion for the reader, whereas consistent location of the results, the discussion, the conclusion will help the reader in understanding the report and understanding the clinical implications of the result. We will see a lot of examples in the coming slides, so don't hurry, we have a lot of time. Each report should have the following components. First, the demographics, the indication of the study, the technical or procedural explanation, comparison or supplementary documents, the body of the report, the summary or the impression, and the signature of the radiologist. We will talk about them one by one. First of all, regarding the demographics, it helps us to ensure that these are the correct images for the correct patient. The image being interpreted is the correct type of study. It has the correct date, time, and the study identification number. By comparing the appearance of the patient to the prior one, if possible, if we have all the study, compare the new one to the old one to ensure that this is the same patient. It's not a different patient by any mistake. We inspect the image annotations, ensure they are correct, whether it's with contrast, without contrast, and things like that, to explore steps and they also should help to explore steps to take in case of correction of mismatch or incorrect image. If this was an incorrect image, not the same patient, why did this happen? How can we help prevent these things in the future? Second thing to write is the indication of the study. So this helps to understand the appropriate reason for the study, why the study is being done, and we have to document them in the report. Also, we should it's an attempt to identify the reason of the study. If not given, we should try ask the patient as the referring doctor why this CT or MRI is done, and to document if there is no reason can be identified. Even that we should write it. There is no apparent reason in case we could not identify any reason. And we have to issue an addendum if the history or the reason becomes available. That alters the interpretation. If we interpret the image, we have no apparent reason, and then for some reason we know what's the reason. We should put another addendum or something extra later to say this study was done for that reason. The technical or the procedural part, we should write it to communicate the technique of the study performed. How did we do it? Any contrast, any medication administered to the patient, any deviation from the routine procedure, we did something different from what we do routinely. What was that and why it's done? And to document whether there is any limitation of the study. Is there anything that was not done? Why it was not done? We should write that. Guys, can you mute yourself, please? We have some sounds of some children, I don't know what. Let me see who's unmuted. I might be able to mute them. Well, anyway. So, in case of comparison or supplementary studies, that we should write them to recognize the need to make comparison to the prior studies, to document appropriate comparison studies used, and to learn to use the supplementary data if available, and to document its source. From where do we have this supplementary data? And to attempt to explain or resolve discrepancies in the result, if they exist. If there is a difference in the results, why is that difference? We should try to explain it. Now to one of the most important parts of the report, that is the body of the report. The body of the report, it's approaching the radiological study as if it were a scientific test and will help limit the findings that need to be described. We treat the study, the radiologic study, as if it were a test in the lab, the same thing. We assume a null hypothesis. Guys, please mute yourselves. Please, if you can't, just mute. I will mute all. Okay. So we should use what we call a null hypothesis. We treat every patient that we try to prove that the patient is normal. We try to prove that the patient has nothing wrong. And any abnormality we see, we describe it because it will disprove the null hypothesis. Okay? This abnormality we call the positive findings. So we assume that the patient is normal, and then we try to disprove that. We try to prove that the patient has something wrong. We don't treat the patient as he has something abnormal to start with. We treat him as he's normal and then try to disprove that. The exception for this rule is when the clinical question implies the possible presence of a specific abnormality. If the referring physician says CA lung or the known case of lung tumor, and we should, if we don't find a lung tumor, we should write there is no evidence of a lung tumor, because this is an important negative. Okay, so these called pertinent negatives. We will see that in the coming slides, make it even more obvious. So the findings should be described in a clear and concise manner, and to organize your ideas and the report in a way that emphasizes more important findings first. We start with the more important findings, and then we go to the less important findings. And to construct a complex report using methods such as grouping comments and to separate paragraphs to increase clarity. We put each paragraph separate from the previous one to make it more clear. We don't just write paragraphs one after the other, and we have to articulate clearly what the image findings mean and to communicate the significance of the findings. The referring physician will not care if you say there is a T2 hyperintensity in the I don't know where. What does T2 hyperintensity means? You have to say that so that you make sure that he understands. After the body, we write the summary or the impression. Keep in mind that in a large survey, more than 50% of the referring physicians, they read only the impression of the radiology report. They don't read the rest. So this is a very important part of the radiology report. We should summarize the findings towards a diagnosis or a differential diagnosis if the diagnosis is not possible. Okay? And we have to list the most important findings first and to answer the question asked. What's the question? This is the answer in the summary or impression. And we need to offer suggestion if further evaluation is indicated, what kind of further evaluation, and to mention any outward reaction to medicines or contrast administration. We should mention the patient had an adverse reaction to contrast, so that in the future we be careful from these kinds of reaction. Also in the summary of the impression, the common practice of using numbered list for the impression section help to produce a concise summation. We write 1 lung tumor, 2 metastasis to liver, 3 metastasis to the bone. Just number them so that in the future can be followed logically, and to make use of the implied ranking. That we know that the first one is the most important one, and second one is less important, third one is less important, and so on. The statements in the number list should maintain a parallel structure. What do that mean? If complete sentences are used, use complete sentences in the next one in the list. If you use phrases in the next items on the list. And for clarity, it is best to limit each numbered item to a single sentence or single phrase. Okay? Sometimes you need to add a footnote to the report to make it more obvious. For example, you add the phone, fax, email, time, is it life-threatening information, because sometimes it is the standard of the practice. Sometimes you need to add communication to separate from the report itself. For example, you need to add note: the doctor was contracted at phone number this at this time, and the result was discussed with the doctor. Or the fax of the we faxed the report to this doctor, or a copy of the report was sent by email to this doctor, so that you protect yourself legally. I send this report to this doctor and tell him this and that. Now, this is the most interesting thing of this talk. The terminology that we use in the radiology report should be concise and brief, and should be clear and should be pertinent. We will discuss every one of that in the following slides. First, what do we mean by brevity? We should avoid starting the sentences with there is or there are. Such sentences can nearly always be combined with the next sentence. For example, what do we mean by that? If we say there is a speculated mass in the right upper lung lobe, this mass measured 5 by 4 cm. This finding is suspicious for a bronchogenic carcinoma. We can replace it by a 5.4 speculated mass in the right upper lobe suggestive of primary bronchogenic carcinoma. This is more shorter sentence with the same meaning. So we don't say there is a speculated mass in the right upper lobe, this mass measured this by that, this finding is suspicious for you just mix them together. A mass measuring this by this in the right upper lobe suggesting primary bronchogenic carcinoma. It's short, it's brief, it's precise. Okay? Avoid impressions that are simply descriptive, just to describe. For example, a rambling description of findings without a reasonable conclusion does not add anything positive and does not prevent successful litigation. Litigation means going to court. So you don't just describe without important descriptions. Just focus on the important descriptions. The mass measured this big and it's located there. The size is this is the I don't know what, and there is density that is I don't know. It's just a lot of description with no benefit, no help to the doctor. And avoid redundant phrases. Redundant phrases means extra or useless phrases. What do you mean by that? For example, if you write a review of the scan of the bone window shows no evidence of metastatic disease, that's redundant. You can write no bone metastasis seen. That's it. It implies that if you write no bone metastasis seen, means that you have examined the bone window, the appropriate window, and there were no bone metastasis. You don't write review of the scan at the bone window. This is redundant. It's extra. No need for that. Okay. You can write the lungs are clear. It means that you reviewed the lung window and they were clear. So the word identified and other similar terms are frequently overused. Don't mention a lot of identified. For example, if you write the right lung nodule is again identified and unchanged, it's redundant, it's extra. You can write the right lung nodule is unchanged, and that's it. No need for the word identified and the similar words, some similar words to that. Okay. Long-winded terms such as normal or unremarkable does not add to the report. They add needlessly to length and may ultimately convey less meaning. For example, no focal liver masses or intrahepatic duct dilatation seen. The liver is unremarkable. This is a long sentence. You can make it much shorter. You can remove these words. For example, no focal liver masses or duct dilatation. That's it. No need for the extra words. And if you write this sentence, no focal liver masses or intrahepatic duct dilatation seen, the liver is unremarkable, this sentence does not exclude the possibility of diffuse liver abnormalities such as cirrhosis. You did not rule that out in this sentence. So make it short. We radiologists feel the need to make a long report. It's wrong. Make it short, make it focused, and focus on the important things. No one cares about the non-important things. The second point is the clarity of the report. Is it clear? Is it understandable? The radiologist should be aware of the intended reader of the report and how that reader will understand what's written. If I were this physician, what will I understand from my words? Sometimes the caregiver the nurse will read the report. Sometimes the patient will read the report. So failure to clearly communicate the result continue to be the leading cause of delayed diagnosis and the resulting lawsuits. You need to communicate the result clearly with no doubt. Okay? So we use plain English instead of radiology jargon or abbreviation. You know, radiology jargon, these are words that only the radiologists understand. The non-radiologist does not understand. So avoid using the radiology language, let's say. Use common language that everyone or many people will understand. For example, use the word center instead of epicenter. Use the word no instead of no significant this and that. Use the word suggest X suggest this instead of suggesting the presence of this. Use just suggesting cancer instead of suggesting the presence of cancer. Use the word metastasis instead of mets. Metastasis is more obvious. Okay. The term that we commonly use is evidence of. The word or the sentence is evidence of should only be used with findings which are inferred and not directly observed. What do we mean by that? For example, portal hypertension. Do we see portal hypertension? We don't see portal hypertension. We see the effect of portal hypertension. We saw the portal vein dilated. We see collateral vessels. We see the splenomegaly. We see liver cirrhosis. This indicates portal hypertension. So the word evidence of, you just use it for the findings which are inferred, which are concluded. You don't see it directly. For example, you don't write no evidence of portal venous hypertension. It's inappropriate. You write inappropriate to say no evidence of pleural effusion. Pleural effusion, you see it. So you don't write no evidence of pleural effusion. You write no pleural effusion. These are directly observed findings. While portal hypertension, you don't see it directly. You write no evidence of portal hypertension. I hope it's obvious. You write no evidence of portal venous hypertension because you don't see the portal hypertension. You see the effect of the portal hypertension. While you see pleural effusion. So you write no pleural effusion. That's it. You try to avoid the word significant. The word significant, try to avoid it. And why? Because if you write no significant adenopathy, does this mean that there is insignificant adenopathy? Either there is adenopathy or not. You don't write no significant adenopathy. Okay? Use active rather than passive tenses. What does that mean? If you write the pancreatic head mass obstructs the common bile duct, you may write the pancreatic head masses causes obstruction of the common bile duct. Causes obstruction of the common bile duct is active tense. While if you write pancreatic head mass obstructs the common bile duct, it's passive. Both of them are correct, but if you use active words, active verbs, it's better and are clearer. Again, something that we use commonly. The phrase cannot be excluded. The sentence cannot be excluded. Should be avoided as much as possible. It is a grammatically undesirable double negative. Cannot be excluded. Okay? Double negative, it's incorrect or undesirable. And it's used differently by radiologists. For example, if you write a speculated 4 cm lung mass bronchogenic carcinoma cannot be excluded. Okay? Well, the meaning that you are meaning to say a speculated 4 cm mass bronchogenic carcinoma is likely. Okay? So try to avoid the phrase cannot be excluded. You say is likely to make it clear. When the diagnosis is mentioned, but When the diagnosis is mentioned but considered unlikely, other options are to state X is a remote possibility or consideration. For example, you write a cyst seen or a mass seen in the lung. Carcinoma is a remote possibility or consideration. Okay? You don't write carcinoma is not considered or cannot be excluded. Avoid the word cannot be excluded. Either it's likely or it's more in favor of carcinoma or it's unlikely. Or don't use the word cannot be excluded. It's very unclear. So, unfortunately we have only like 10 minutes left, so I don't know whether we can finish or not. We'll try to do our best. Do not use terms that have little or no radiological meaning. What does that mean? Some people might write shorty lymphadenopathy. It's a clinical term for lymph nodes which have hard granular texture on palpation. It has no place in radiology report. Don't write that. Certain terms are interpreted differently by clinicians than by radiologists. For example, collection is, people think of it as abscess. Okay? So don't use the word a fluid pocket or a fluid filled structure. This, it's not very obvious. So fluid collection, which may be sterile or infected, it's better. Okay? So don't use this fluid pocket or fluid filled structure. Fluid collection, which may be sterile or infected, means it can be abscess or not. Okay? Now, statements such as careful examination of the retroperitoneum, don't use it. They could be taken to imply that other body parts are not carefully examined. Okay? So don't use these sentences. Certain terms have no uniform meaning. Certain words, they have everyone understands them the same. For example, there is a little chance that our referring physician understands what we mean, but it's not universal. So don't use some terms like, for example, non-specific bowel gas pattern. What does that mean? It's understood by different radiologists to mean either normal bowel gas pattern, equivocal bowel gas pattern, or abnormal bowel gas pattern representing ileus or obstruction. Don't use these vague terms. Be precise, be specific. Sufficient details should be provided to allow the person reading the report to visualize the findings. He should be able to see them with his mind. The size is a very critical feature. Don't forget to write every mass, it's measured like that, this by this by this, it's better. Some lesions are not discrete, are not obvious. So write semi-quantitative assessment for tumor volume and semi-quantitative. Well, this thing is subjective. I might write it something different from you, but it's better than nothing. For example, you can write small volume infiltrative retroperitoneal adenopathy. You cannot measure the retroperitoneal adenopathy. You cannot measure every lymph node. So you just write small volume or large volume, something subjective. Now, let's talk about the pertinence. What do we mean by pertinence? Pertinence is importance. Findings of no clinical relevance or doubtful interest to the body of the report, don't write it or write it at the end. Okay? They do not belong in the impression. Don't write them in the impression. It is unusual for a clinically relevant impression to consist of more than 3 points. Impression should have not more than 3 points. For example, multiple stable renal lesions that are too small to characterize in a patient with a progressive lung metastasis. Okay? What does that mean? Another example, dependent atelectasis. Dependent atelectasis is very common. We see it in many patients who are normal. Patient lie on his back, there is some atelectasis at the base. So do not write this unless it is severe or it indicates that an infiltrative or interstitial disease. Just normal dependent atelectasis is normal. Don't write dependent atelectasis seen. It's confusing and it's not important. Okay? The impression should be ordered by the importance of the findings rather than following anatomical list. You don't start from the brain to the head to the lung to the abdomen. The important finding is, for example, gastric mass or liver mass. Start with this. Start with the important finding. It is confusing to read impressions that begins with, for example, small hiatal hernia or a gallstone, and then you write a new bone metastasis seen. You start with the bone metastasis, not the hiatal hernia. So, it's important to include pertinent negatives. When hydronephrosis is seen, it's important to comment on the presence or absence of renal cortical loss, level of transition from dilated to non-dilated ureter, presence of stone, absence of stone, any obstructive mass. These are important negatives. When the findings are truly non-specific or equivocal, it is better to offer advice on the appropriate next test. What should the clinician do? And from a practical point of view, a differential that includes 4 or more diagnoses is not helpful. Your differential not more than 3. More than 4, it's 4 or more, it's not helpful. The term, if clinically indicated or clinical correlation suggested, should be used very rarely and should never be used as a substitute to offer a diagnostic opinion. You offer your opinion. To suggest a clinical correlation for a solitary 4 cm solid non-fat containing renal mass, it's inappropriate. This should be treated as a renal cell carcinoma until proven otherwise. It has no fat, it's a mass in the kidney. You don't write clinical correlation is recommended, even if there is no hematuria or no other symptoms. Only additional investigations that are truly likely to be diagnostic should be suggested. You add something that should be diagnostic to the patient. For example, suggesting a pelvic ultrasound to further evaluate a lobulated heterogeneous uterus seen on CT scan is of doubtful utility. It will add nothing. If you do a CT scan for mass that is seen, you suggest ultrasound, you see the mass in the CT scan. What will it add? Most likely the ultrasound will show also a mass in the uterus that is most likely to be leiomyoma. Don't suggest that. This is useless. Comparison of the studies that are critical, it's critical in radiology and especially in cancer imaging. It is important to state that the date and the type of the previous examination at the beginning of the study. For example, you write compared to the prior CT scan of at that date, or good practice also to begin the impression with the date of the prior study. For example, impression since this date interval progression of hepatic metastasis was seen. Okay? It is not always sufficient to compare the current study to the most recent. We usually compare the current study with the most recent study. This is not enough. Sometimes we need to go to the earlier studies to show that the progression of malignant disease is a slow progression, or the disease is being long-term stable, it did not change over time. The comparison phrase was not seen on the prior study. It's not obvious, it's ambiguous. Don't use the liver mass was not seen on the prior study. It's important to state or to say if the lesion was or was not visible on the prior images, even if it was not reported. The lesion was not seen or was not present on the previous CT scan, okay? Or the lesion is present on the previous CT scan, even if the report was negative. You write the comparison that you make now, not the old one. The term too small to characterize should be used cautiously. The term too small to be characterized, don't use it commonly. For example, sub-centimeter hypodense lesions may be too small to characterize by CT density measurement, but comparison to the previous study will show you that the lesion is present or not. If it's present, the number is the same or less or more. For example, sub-centimeter lesions which have stable for many years, most likely benign, while multiple new subcentimetric lesions are more likely to be metastases. False reassurances should be avoided. Don't reassure. For example, spinal metastasis without evidence of epidural extension on a CT report is disregarded the fact that the routine CT is not accurate in this assessment and may give false impression to the clinician. When you see spinal metastasis and you write no evidence of epidural extension, this is wrong. You don't evaluate epidural extension based on the CT scan. You need MRI. So don't write that, okay? So this is an example of the clinical of a report that most likely typical. Sorry for that. This is an example of a history of a report that will be of more typical. What do you mean? For example, you start with the technique, the institution specific with the post-processing that we used for in this institution, and necessary billing and coding purposes. If the scan was unenhanced, axial images that are used for adrenal gland, for example. If there is a lipid-rich adenoma identified on non-contrast image, this following part should be deleted. For example, intravenous contrast scan transaxial images through adrenal glands, and this timing imaging was continued through the abdomen and pelvis, may or may not. After this time delay, we did the same image on the adrenal gland. IV contrast, this amount of IV contrast used was the name and the concentration of the IV contrast. Oral contrast, if it was used or not. CT radiation dose should be reported, and comparison was done with the previous image done on this date. The observations are this and this: that right adrenal gland is normal, while you should describe the characteristics of the adrenal mass, replacing the default statement with the following. For example, an adrenal mass measuring this by this millimeter, the mass is homogeneous or heterogeneous in attenuation or on unenhanced images. The unenhanced attenuation is this. The adrenal mass measured this on parenchymal phase images. The adrenal mass measured this on delayed phase images. The absolute washout is this percent. The left adrenal gland, the same thing you report, or you can say the left adrenal gland is normal. This is regarding the important part of the study. The remainder of the study, you write the liver is normal, the gallbladder is normal, spleen, pancreas, blah 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 blah, this whole thing, normal or abnormal. In the impression, you write normal study of the adrenal gland, for example. Or you say left or right or bilateral adrenal mass keeping with lipid-rich adenoma or lipid-poor adenoma or myelolipoma. This lesion does not satisfy the CT criteria for definitive characterization. Or you might write differential diagnosis include this and this. So this is just an example. I hope what we said was good enough, and I hope you find it useful, and I hope to meet you again. Any comments or questions, I would be grateful if you write them on the YouTube channel and in the Telegram channel. Thank you very much. See you next time. Thank you. Goodbye.